Good morning, everyone. Thanks for joining us for this webinar on workforce supply and demand within Ohio's behavioral health system. I'm Lori Chris, the Director of the Department of Mental Health and Addiction Services. And with me today is Doug Day. He'll be leading us through the research content portion of the slide, so the meat and potatoes there. And we're looking forward to sharing this information. At the end, there will be an opportunity for question and answer, so please put those in the chat. Nicole Marks is monitoring that, and we'll be able to have some question and answer, assuming there's time left in the time we have planned together. So to get started, for many years, Ohio has looked at workforce demand and supply and behavioral health. And nationally, we know there have been specific studies and research projects that have pointed out waning interest in joining our workforce and the ongoing inadequacy of the supply of the workforce compared to the demand for services and supports. And rather than continuing to study and identify workforce gaps and challenges in that way, our department partnered with the Office of Workforce Transformation and the Innovate Ohio office to set out to understand what's impacting and the factors affecting the incoming, ongoing, and outgoing supply of workforce for behavioral health in Ohio. And it was important for us to also create new ways to understand the current and future impact and factors related to the demand and supply of behavioral health workforce into the future as well. So as we pushed forward with this work, we knew that we had the opportunity to drive a more focused, data-driven approach to workforce development strategies. And like all data, the data that we'll see here today, the information resulting from this effort, will help us start conversations, likely cause us to ask more questions, and search for more insight into what the data says and what it means for us together strategically as we support workforce development, recruitment, retention in Ohio's behavioral health community-based settings, inpatient settings, and beyond. This data is largely focused, the data that we were able to look at so far was largely focused on medically necessary, clinically driven data set. So you'll see that while we have a lot of great information there, we don't have insight fully into prevention and recovery workforce. And so wanted to acknowledge that straight up at the beginning. That's not work that was forgotten. It was just not as easily available. And so strategically, we will be looking at that as we continue to improve on this first effort. Today, what we'll learn together is the findings from the study that was conducted. We'll also talk about where we're going from here and review current and planned investments in behavioral health workforce. I want to thank and acknowledge our partners at Innovate Ohio and Deloitte for their efforts with this project as well. Innovate Ohio, under the leadership of Lieutenant Governor Husted, is providing integrated and scalable data capabilities for state agencies to help better serve Ohioans and ultimately make Ohio a better place to live, work, and do business. And so we're grateful for the IOP's true partnership and their leadership with this work as we move through this innovative project together. I also want to thank the numerous state partners who contributed to the data set that resulted in the information being shared here today. And we'll rely on that into the future as we work through planning and strategic investments in workforce together. And of course, I want to thank our team here at the Department of Mental Health and Addiction Services for their dedicated work on this analysis. And now I'm going to turn it over to Doug, who will lead us through the project summary information. Thanks, Doug.
Thank you, Director. Next slide, please, Nicole. So let's just start with a little basics here. There's 4 components to this project. The first one was looking at Ohio-specific data and doing an Ohio-specific analysis. Oftentimes, these projects result in a static report that then needs updated sometimes every few years, or sometimes you realize 10 years later, it's still the same report. And a lot of times they're at the national level. We thought this was a good opportunity to leverage our state partnerships to look at specifically Ohio. We then analyzed or did the work with Deloitte to look at the supply and demand, comparing historical and projecting future. We'll talk a little more about that in a minute here because there are some nuances there due to our databases that we could access. The result of the project was this dashboard. It is not available right now. I'll say a little bit more about that towards the end of the slides about what is available on the dataohio.gov website. But the dashboard is not actually turned public facing. It's not even living there right now. But it is something that we approached with an intent to have some level of public use for it. It was not intended just to be solely for state use, because we think there's a lot of value to others having the ability to go in there and test hypotheses or theories, if you will. But then looking ahead, you know, the way the state does its contracting, there isn't any way that we could have necessarily put in there ongoing upkeep and maintenance on it. And we can talk in a few more slides about some of the things that change over time that we would need to put in there. And while we're here, I would like to, you know, the director mentioned about prevention, and this is very clinically heavy. We did have the opportunity to include information on peers, although it's not very complete and it's a new and emerging area. But that's an example of where we were looking prospectively and said, let's go ahead and get something in there that we can see so that we can actually watch what's beginning to happen over time with that area. So next slide, please, Nicole. So a little bit more. As I mentioned, this was Ohio. We created a detailed picture across the state. We did this independent of the settings that the practitioners are working in because we have access to practitioner data. But one of the things we didn't have access to was claim data, private claim data. So there is some science, if you will, behind calculating that and looking at that so we get the entire or an entire picture for the state. We can look at specific practitioners and practitioner groups. We mentioned sometimes during BH redesign that that's one of the values of having rendering practitioners. So some caveats there, though, is when we get into team-based care, it's not as precise, but there is still a recognition of a practitioner associated with those services. Snapshots, we can do snapshots of supply and demand. Comparisons, you'll see some later where we talk about them by county. There is a board view. Since we do have the board system here in Ohio, we put that in place. There are some assumptions in here, and I think it's important to note here that just like everything else over the past couple years, we had the COVID public health emergency interruption, for want of a better term, and you know, the rapid implementation or transition to telehealth. So some of the assumptions may not be completely accurate anymore, but again, that's that kind of maintenance factor. We do or ask them to code in the projections over a 10-year outlook period. So you can see roughly what happens over the next decade. And you can also test things. This is meant to be more of a, think of it as a laboratory setting where you can come in, as the director mentioned, you have an idea and you can say, okay, let's see what happens if we alter A, B, and C, what happens with W, X, and Y. So it's really meant to be used and utilized, if you will. So next slide, please, Nicole. So in creating our specific Ohio analysis, on the left side here in the box, these are all, actually I want to say most of the partners. I think we had a few others that may not be in here, but e-license was a big one. And that's why you see all of the professional boards in there too, because not just do we have to work with e-license, which houses the licensing data, but each of the boards had to give us permission to actually use their data out of there. The Innovate Ohio platform was very key in terms of working with us to release the RFP, staying engaged through the project with Deloitte, facilitating additional access to additional data if we needed it. And Department of Medicaid was very key because they have a huge claims database that we utilized. plus our own board level information database that we get here at the department. So, kind of what we did differently, I talked about this a moment ago, is we really drilled into what was available here in Ohio. So even at the beginning of the project, that's one of the things that Deloitte did for us, was they had to look into, do we have enough data that they could use it to begin to create this product? I might call it a tool sometimes. That's just term of art that we were using when creating this. And they said statistically and mathematically that we had enough and they could work with it. So that's how we got to our product that we have. You can segment data across many different variables like county or the practitioner. Ages, I think we have split into basically children and adult. Facilities, when you see that, think about provider settings and service types. We actually, when it comes to services, we talk and can look at them either comprehensively as behavioral health, or there are options to look at mental health and SUD independently. So again, state-specific information. Big one was the e-license data. We did have access to higher ed data. You can get some demographic data out of e-license, but self-reported, so it's only as good as what's put in there. And then forecasting, we coded it so it would forecast across the state. So the impact is that you can look at behavioral health demand at the county and board levels. We thought it was important to start. We actually started with the county level, but then Deloitte offered and we let them group it into the board level because that's part of the system. Detailed demand breakdown to identify behavioral health needs. Again, even though we do look at comprehensively as behavioral health, you can look at SUD and mental health segmented in there. Looking at comparisons of the actual supply, who's here and who's working compared to demand, and identifying key areas where variance is growing and or shrinking per the model. It's important to note here that all of the data slides you will see coming up are using the default parameters. You can go in and change some of those parameters, but for presentation purposes, we just kept the default views, if you will. So next slide, please, Nicole. So these are just kind of questions to keep in mind as we go through this. You'll see calendar year 2013 is mentioned in here. That's the base year we started with in terms of looking at the data. Prior to that, there were some gaps that Deloitte didn't feel comfortable trying to fill in. Who are the groups of people that are receiving behavioral health and how's that demand changing over time? What are the trends again? And how do the current and projected demand and supply landscapes compare? So next slide, please, Nicole. So this is a snapshot of what we did to analyze the historical demand. 7, thank you. As I mentioned, the base data set starts with calendar year 2013. That seemed to be the most stable when we were pulling all of this together, and Deloitte made the recommendation and we moved forward with using that as the base. Even though there's a little bit of a difference, you see the MHAS data is 2014, but they felt that using just Medicaid in 2013 gave us that little extra year and a little boost. One of the big changes with BH redesign is some of the codes come in as encounters. In order to set a common way to do calculations, Deloitte came up with ways to convert those into time. I'll explain a little bit more about that and some of the other parameters here in a minute. Obviously the quality is subject to the validity or quality of the input data sets. And when doing that time conversion, just for sake of the mathematics, it was defaulted to the highest time in the band, if you will, just to get us somewhere to start with. So the analysis side total BH demand for Medicaid and MHAS populations. So we looked at met and unmet. And as I mentioned, sometimes you separate, or we separate them by the two disciplines or conditions, the mental health versus SUD, as there are some unique services, think ACT for mental health and SUD residential for the SUD side of the house. Data was looked at for each year. We looked at ages, the conditions, the county, the service type, the facility, again being the setting, and the practitioner type. Assumption in here is that we used an 80% work efficiency. You might call that productivity. Deloitte went and looked at a couple of national studies, and that's what it defaults to. That is a variable that can be changed, but we had to code something in, so we used the 80% from those national studies. And prior to redesign, as everybody knows, rendering practitioners were not there, so they had to do some proxy or extrapolation to the claims when rendering was not available. So then they get into extrapolating or projecting the demand looking forward. So they look at the history in order to do the projections, if you will. And because, as I mentioned, there is not, Ohio doesn't have like an all claims payer database. So they use the Medicaid claims to extrapolate to the general population. And geographic analysis is based on the location of service associated with the provider. As I mentioned, we got caught in the middle of this with the COVID public health emergency and that accelerating use of telehealth. So we should probably and plan to do some work in the future on looking there. And then we have the projections on the demand, total demand. We do have something in there that looks at insured demand, and then projected meetable demand that you can look at and move. So next slide, please, Nicole. So we asked Deloitte to just give us some overall key observations, as we're calling them. These are not interpretations of the data or assumptions. These are just facts of what they saw when looking through the information and creating this for us. So, there is no analysis reflected in here of Medicaid expansion, of BH redesign, of COVID and the public health emergency, or necessarily telehealth. These were just facts. So obviously, as we're all aware, it validated that there has been this increasing demand over time. You can see roughly 350% over the time frame here that we looked at, roughly 30% per year. Mental health services are about half of the total behavioral health demand. Substance use disorder services increased in 2018 calendar year, and there seems to be a correlation there to a decrease in opioid overdose deaths and the introduction of new services. So it's a correlation, not an assumption. And then demand also correlates well with the population, although there are regions in Southeast Ohio counties is one of them that show above normal demand. And, that's again, just a fact. There's probably some assumptions we could make about that, but we chose not to. And demand for behavioral health services provided by nurse practitioners and physicians, so the medical side of the house, seems to be increasing or is increasing since BH redesign. And in this terminology, community behavioral health centers, so think of entities that are certified by Ohio MHAS, are the most common place of service for behavioral health services. But there's also hospitals, federally qualified health centers, independent practitioners are in there too. And in adults, there appears to be 2/3 of the demand right now is for substance use disorder services. So next slide, please, Nicole. So the next slides, 9 through 17, are actually data slides, pictures of data results from the tool using, again, the default parameters. So we didn't adjust anything. We just used it to say, what does it look like currently using the projecting capacity here if nothing changes in the state. So there on the left is a heat map showing the demand of calendar year 2019. So the darker the color, the higher the demand. Then on the right type is showing the demand by practitioner types for calendar year 2019. Again, keeping in mind this is a behavioral health one. You do have, or we do have, the options of looking independently at SUD and mental health and a whole lot of other views, if you will. But this is just for demonstration purposes today. So next slide, please, Nicole. So then here's a view that shows where we split it by mental health and SUD, mental health being represented by the red trend line, SUD being represented by the blue. So this was demand by diagnosis. It says calendar year 2019, but if you look at the bottom, it's showing over time. Excuse me for a moment. So it's just a demonstration of how we can separate it into the two disciplines, two conditions, two diagnoses, if you will. So next slide, please. Okay, here's another one that's just facts, straightforward observations that we asked Deloitte to give us without trying to do any interpretation or, try and find causes, if you will. But it looks like the workforce has actually increased between 2013 and 19, which is makes you kind of raise your eyebrow and think, because we don't hear that often. The supply of CD counselors is increasing most rapidly at a yearly average right now of 61%. Social workers make up the largest portion of licensed practitioners, and just 7% is physicians. This one is probably familiar to all of us, but the workforce is generally concentrated in populated counties. And nursing degrees are increasing. And actually, this last one is also interesting because nearly half of the workforce is between the ages of 25 and 34 years of age when this was run. So again, these are just facts. They're not interpretations. And they give you things to start thinking more deeply about, as the director mentioned. So next slide, please, Nicole. Thank you. So then when you look at workforce, these again are heat maps and show, again, that concentration on the left of the workforce. As you can see, the darker counties are the more populous ones. And then on the right are the practitioners. Again, you can see the social workers are the largest. I would like to point out the second one up from the bottom is peers. That's shown because we did incorporate it in there because it's a growing and expanding area of our workforce and our practice. So we didn't want to leave them out, but there's another slide where it looks a little odd, and we think, or there are a couple of reasons that it does look that way, but we wanted them pre-programmed in there so we can watch what happens in that area over time too. So next slide, please, Nicole. This is a view of degrees. This is from, I think, the higher ed information, and it just goes to show how we can look at those degrees issued by the higher ed and or some of the boards. So it's interesting how high up registered nurses are here. So next slide, please, Nicole. So then looking at demand and workforce, when you see the bars going to the left in this left chart, that is showing the unmet demand. The odd one again is peers in there. It looks like there's a abundance, if you will, of peers, but working with Deloitte, we can attribute that to the newness of the practitioners, the evolving and the onboarding of more peers through the certification process. It also is influenced by not having a full coverage through Medicaid. I mean, people are aware that it's covered fairly well on the SUD side, but not nearly as much on the mental health side. So until some of those things are corrected, it's going to have a skewed view, but again, we wanted it programmed in there so that it's there and we wouldn't necessarily have to go back and reprogram around it. So these are just some of their key observations again. Unmet demand in 2019 was around 41%, around physicians and APRNs. Again, peers are the only type with a surplus. Again, that's because of just the, excuse me, current status of peer and current status of Medicaid coverage for peer. The last part in that peer thing is that, there's not an ability to distinguish for any of these practitioners between full-time and part-time. So they're really converted to FTEs, not converted to bodies, if you will. And Cuyahoga, Franklin, and Allen counties are the only ones showing a surplus of practitioners. All others show a deficit right now. So next slide, please. Thank you. So here's a couple of forecasting maps that can be produced. And if you look, on the left side is calendar year 2019. And then to the right are 2022, 2024, and 2029. We only put 3 on the slide, but you can actually forecast for each of the years for 10 years out. Sorry. So in this one, we've got a couple counties highlighted just to show what's occurring with the default data, if you will. Apologize for that. So right now in 2019, Hamilton County is trending towards a surplus. And if you watch over time, the county color actually gets darker. That's the trending there. And then Scioto and Lawrence counties are forecasting to have an increasing deficit. Again, you can tell that because of the colors changing. And then Cuyahoga County increases its surplus. This is according to the forecast in 2024, while Summit County transitions from a deficit to a surplus. And then Knox County is trending towards an increased deficit, driven, according to this, or in the calculations, by a variance in chemical dependency counselors and social workers. So you can see over time that if everything stays the same, this is how things begin to look on a county by county, or we could change the view and do a board by board view, if you will. Next slide, please, Nicole. So just a little bit more on Knox, you can see these are the trend lines between supply and demand. Supply is the blue, demand being the red. You can see how they begin to significantly diverge if nothing is done and just everything continues as is using the default forecasting in the model. So next slide, please, Nicole. So this is just a couple other data points, if you will. The model right now, unchanged, shows variance projected to grow in not just these counties, but these are some we pulled out. For example, Belmont, Fulton, Guernsey, Knox, Scioto, and Lawrence. And trending over time, the practitioners where there seems to be variance, where there is variance growing, is with nurses, physicians, social workers, chemical dependency counselors, and counselors. The bottom one there is just Fulton County as an example. You can pull these charts up for each and every county and look at them individually if you want. And then where variances are projected to shrink right now, here's some example counties: Adams, Clark, or Claremont, I apologize, Darke, Hamilton, Harrison, Miami, Summit, and Union. And for practitioners, when you look at them, LPNs and RNs, peers, psychologists, marriage and family therapists, and QMHSs, and care management specialists, CMSs. So again, the bottom chart is just an example of Darke County. One of ours picked out of the top, couple of examples there. And you can see if nothing changes where the trend line is projected to cross. So next slide, please, Nicole. So at the end of the day, there's, summary and observations based upon how this is programmed and set up. So we have this Ohio data sets that are driving the detailed picture of the behavioral health demand in Ohio. Demand is then able to be segmented out across the counties, the diagnoses, the age groups. There are many different ways to look at it. Provides us a granular view of the behavioral health workforce. So you can go from general to very specific looks by partnering. That's how we got the data sets. Like the e-license data and the education data help us to do that for the workforce. Identifying variance between supply and demand. We talked through a couple of those slides and use them as examples where you can see that using the default inputs and outputs where supply and demand start to meet and either converge or diverge, if you will. And then projecting the future. As I said, it's got this ability to look out for the next 10 years and create those projections to say, based upon the parameters that are coded into the system at the given point in time when it's run, here's what the picture begins to look like. That's a good place to remind you. That's where the director mentioned that it's meant to be very thought-provoking, to go in and say, okay, what happens if I change this? What does the picture begin to look like? Doesn't necessarily lead you to, a very precise conclusion, but you can begin to see as you change the input side, what that does on the output or the demand side, if you will. Sorry. So that's really the bulk of, an introduction, if you will, to the data and the capabilities of this system. Next slide, please, Nicole. I'll shift over a little bit to the data Ohio. So right now, the tool, the Tableau dashboard itself, is not available on the Data Ohio website. What is available, if you go to data.ohio.gov, what you can see is what's called the project card, which is a summary similar to what Director gave at the beginning of the presentation, but it summarizes the project. It gives some of those outputs that I went through, or observations, if you will. If you use the search function, you need to put in workforce supply and demand, what's over there in quotes. And what comes up is what you see here on the right. It's not the most intuitive system, if you will, at the moment, but on the right, what should be returned is, under the search data down there at the bottom, you will see the workforce supply and demand within Ohio's behavioral health system. You can click on that to get into it. I also put the picture over here on the left. There is another way to get into it. So if you come across seeing that with the department logo and the heading workforce supply and demand within Ohio's, and it just gets chopped off, you can actually click on that to see it also. Next slide, please, Nicole. This one has actually the direct link to it on it. So hopefully that will go out as a clickable link in the PowerPoint when we send it out. If not, you can always try typing it in. So that's what's available now. What we are doing is we are still working with IOP and Data Ohio to move the actual dashboard into or onto the platform itself. We still got to work out some security and access protocols. If anybody out there uses Tableau, you will know that you need a little bit of training in order to understand what you're using and how to use it before we just turn everybody loose with it, if you will. We're also very cautious because of how configurable it is, that we don't want people necessarily going out there and coming up with competing results that they're comparing with each other, because unless you use the exact same inputs, you're not going to get the exact same outputs there. And we're also looking at what to do with updates, and we're looking at probably an annual periodicity at this point. New procedure codes come along, so think Ohio Rise at the moment. We're going to have some new services coming on board that we're going to need to accommodate. If we don't, we actually just would not know about them. So that's an important maintenance part. And there are refreshes that are needed to look at, say, all the e-license data and the changes in the practitioner database over time. So with that, I believe, Director, it's back to you.
Thank you, Doug. Great overview. And yes, it is back to me. The other pieces of work that you see here on the screen for where do we go from here are the multi-agency workforce advisory team and then key investments. OMAS is leading the development of a cross-agency team that will engage with stakeholders to create a strategy for building and sustaining the behavioral health workforce now and over the next several years in Ohio. And so that team is being formed right now. And it's also supportive of some of the key investments that many of you probably heard us talk about earlier this week with some of the relief dollars that are available to Ohio right now. The key investments, we want to use this data to help inform how those investments will be made and identify those in collaboration with the priorities established in the Recovery Ohio strategies and in our own strategic plan here at the department. So when we look at the Recovery Ohio workforce priorities, which are on the next slide here, these were identified by the Recovery Ohio Advisory Council, which is a diverse group of representatives from throughout the state of Ohio, different perspectives, industries, experiences connected to both mental health and substance use disorder. And it was clear in the recommendations that building out a workforce is a top priority for the council and for Recovery Ohio. And these are areas you can see here that the committee really identified as wanting to drill down into and pursue strategically through Recovery Ohio and through these interagency collaborations across state government. This needs assessment was the first part of the work, so really better understanding the mental health and addiction workforce in Ohio, but then also building on that to establish career paths into behavioral health, understand the need for different types of professionals and workforce and increasing those numbers throughout the state, promoting cultural competence in our workforce and really creating an opportunity not just to improve the cultural competency of our existing workforce, but to attract and retain minority candidates who are underrepresented in the behavioral health workforce right now. So the Recovery Ohio report has more information on all of these priorities. You can find more information there. We also have this as a significant part of our strategic plan at the department. So workforce is a cross-cutting priority that weaves across all of the focus areas in our strategic plan. We know that we need to drive that innovation in culturally competent, trauma-informed prevention, treatment, harm reduction, recovery services for people of all ages. Also in the development of policies and procedures within our own department, making sure that we're supportive of the workforce and the success of building and retaining workforce, and then strengthening collaboration and reinforcing that internal culture as well. So even within our own services systems that we operate here at the department, how we support the community and how we operate our own systems with the hospitals, direct service providers, and our partnership with DRC and others, this is a critical part of the work that we're doing. Next slide. So I do want to touch on the building a diverse workforce as well. As we look at our cultural and linguistic competency plan and the strong work that our DAC committee is undertaking and the focus areas that they'll be engaged in over the next several years with their strategic plan, making sure that we are supporting the existing workforce becomes a top priority, and again, improving the diversity of our workforce. So we know that as we look at building out workforce as needed in different parts of the state, that we have to be engaging minority candidates and considering how we can attract more people of color and more diversity into our workforce and community-based settings, and degreed and non-degreed positions that are available. Next slide. at its most basic level, this is what we're looking at as we start to consider how to expand and retain Ohio's behavioral health workforce. We know, if you're looking at the left side of this chart, these are the facts that we can see through the analysis that we've done here through this effort. We know from prevalence studies that 21% of Ohioans are living with a mental health or substance use disorder. We're also watching that data as it's changed because of the pandemic, and that percentage may increase with mild to moderate symptoms for mental health and substance use disorders as well. We also know that while we have seen an increase in the availability of workforce, when you look at some of the charts that Doug was sharing, it's not increasing at the same rate as the demand for the workforce. So that's an important part of what we're looking at here. We know there are still wait times that are largely impacted by the availability of workforce. We know, we hear the stories that there are dollars available to pay people to work, but there aren't candidates to fill those positions. And that's resulting in a wait and a lack of access to care in Ohio. So strategically, we need to address this together and do so aggressively now. We're looking at how we can increase career awareness. So starting middle school, high school, really thinking about careers in behavioral health as part of STEM careers. This is healthcare. How do we get people to think of it that way and attract them into this workforce, create those visible pathways of what's possible and how they can have a fulfilling career in behavioral health. Also supporting recruitment into careers by making sure that we have a full look at what kinds of scholarships, paid internships, stipends are available, both at higher education institutions, community colleges, and with employers in the behavioral health space as well. Also looking at incentivizing retention, and you've seen some of that happening already. We'll talk about that in a minute, and supporting contemporary practice. So what we want to make sure that we're doing too is supporting those who are in practice and giving them the tools that they need to feel competent and fulfilled and supported in their ability to help people achieve the outcomes that are desired. As we start to look at the key investments that we've made in the DeWine administration, here's a quick summary of where we were focused in fiscal years 20 and 21. The community workforce trainings, really building out those ancillary practitioners, really not even practitioners necessarily, but people in our communities who can help be the front door to reduce stigma, to make it easier to find help and to connect to help and support. And so you can see that in the investments that we made in a lot of the citizen workforce activities with mental health first aid, gatekeeper trainings, growing recovery supports, so non-clinical supports, and stigma reduction efforts too. Also supporting those in medical professions and those who identify themselves as healthcare providers, not necessarily behavioral healthcare providers, and opportunities there. Supporting the behavioral health workforce very specifically with trainings, opportunities, but also with tuition reimbursement and loan repayment. And then supporting paraprofessionals and having more of a presence in higher education with opportunities for curriculum development and trainings and residency programs as well. Moving into the current biennium, you can see that we built on that. We have a strong foundation for the community workforce and the citizen workforce, and we're continuing those investments. Those are great partnerships that we have throughout the state that are extensions of the behavioral health system that we value. But really focusing more in on behavioral health professionals, how we can use resources to support healthy workplaces and sustain the existing workforce, retain them in the environment because we're supporting their success through tuition reimbursement, loan repayment, and most recently we put out some dollars for retention bonuses as well. We have $5 million in the workforce retention opportunity. These are one-time awards of up to $50,000 per certified community behavioral health provider. So those are organizations certified by our department in outpatient settings, for retention bonuses of up to $2,500 per person. That application closes tomorrow, and it was open to certified providers, providers who are certified by our department. So that closes tomorrow at 5 p.m., October 22nd at 5 p.m. If you haven't applied, please do so. We'll be continuing to make those awards, start making those awards over the next 2 weeks. We also have $3.5 million per fiscal year for workforce development initiatives that include work in supporting child and adolescent behavioral health, Center of Excellence, and the practice of evidence-based practices associated with the Family First Prevention Services Act and Ohio RISE. We know that we need more MRSS capacity around the state, so a big focus on mobile support for families, youth, children who are having behavioral health crises. And then we recently announced the availability for prevention specialist support through our OCAM and Adult Allies trainings as well. So supporting coalitions, supporting adult allies in their ability to grow the prevention workforce in the state. And we have a little over $1 million for the Appalachian Children Coalitions, and this is to provide funding for training, hiring, and retention of entry-level mental health and behavioral health workers in school settings. So these were all investments made in the current biennium. There's also a note on the Prevention Center of Excellence. This work will be led by the Ohio University Voinovich School of Leadership and Public Services, and will allow the capacity building across the state for the prevention workforce to be coordinated in a centralized way so that we can be more intentional about growing the prevention workforce, supporting culturally relevant approaches that can be sustained and accessible by all Ohioans over time. Next slide, please. I'm going to turn my light on here. It's rainy downtown, so it's pretty cloudy and it got dark in here. Earlier this week, we had a webinar with our sister agencies at the Department of Medicaid, Developmental Disabilities, and Aging, where we talked about the American Rescue Plan Act Home and Community-Based Services waiver opportunity created through CMS with the Department of Medicaid here in Ohio and its partner agencies, again, the ones named already. We have worked very closely together as sister agencies, and we've also had an opportunity to compile and submit a report to CMS that shows what our intention is with the dollars that will be available through these relief funds. And that plan was submitted and made available, submitted earlier this week and made available to all of you publicly as well. The submission of this plan keeps the conversation moving forward. So it's not interpreted, it should not be interpreted as the final version. This is not the landing spot. This is a continuing conversation with our local partners, you and with CMS. And we certainly include in our local partners the legislature, who will help support and appropriate these funds too. There will be more opportunity for stakeholder and legislative engagement. We appreciate the engagement that we've had so far. We had over 500 surveys responded to, responses that came in the summer when we initially asked for feedback on how to use the dollars, and we took that very seriously, and it significantly impacted the design of how these dollars would be used over time. There are 4 buckets of funding in the HCBS ARPA plan, and you can see those here. That's immediate provider workforce relief, so those dollars will be available. Technology enhancements, for us, that really will mean a lot of enhancements and opportunities for health information exchange and for care coordination strategies among providers. Also, workforce support to sustain and enhance it. You will see in this plan that we have marked $230 million to go into workforce development for behavioral health, developmental disabilities, and aging industries. This will require collaboration across state agencies. And so when I was talking about the multi-agency workforce team that's coming together, that's to help build this out. We'll be partnering with universities, community colleges, career tech schools, workforce boards, and you as employers of the behavioral health workforce, and also with boards, the local planning bodies for the full continuum of care as well. So we're looking forward to diving into that work with all of you. This is a significant investment over several years. We believe it will have a long-term impact into the future on building that pipeline for a high quality workforce for behavioral health in Ohio, and we're excited to launch into that. With that, we're at the end of our slides. We have a little bit of time left together. I'm happy, Nicole, if any questions have come in, Doug and I could answer those now.
Yes, good morning. Our first question comes in from Teresa Lampole saying, when speaking of demand, is this really tracking changes in service utilization? How does this capture waiting lists or other unmet needs?
So it really is, and Doug, if you're able to pop back on, it really is looking at service utilization. That's an accurate interpretation for the data that we had available out of the gate right now. As we are able to add additional data sets, especially those that would be consistent across the state, we would be able to look at that demand beyond just the service utilization. And as Doug mentioned before, the service utilization that we have access to is the publicly funded system. So we don't have the private claims either. And we know that the workforce is both serving the publicly funded patients and those who would have private insurance as well. So definitely data limitations, but it's a good first look and causes us to ask more questions and seek more data.
Our next question comes from Heather Wells. Do you think the trending data will change once 2020 data is included?
We expect that the data will change over time, and that was the importance of not just having stagnant data or data that looked retroactively, but having prospective data and the opportunity to have this refreshed at least annually and to have the ability to analyze it over time. I mean, our full intent is with this significant investment in workforce that we will see positive changes and we will be able to make more nuanced adjustments and decisions over time as we start to look at which professions are gaining ground in terms of access and capacity, which parts of the state need more workforce development efforts. So really expecting it to change over time and using the data to help us change our strategies and investments over time as well. Doug, would you add anything there?
Nope, I think you covered it well, Director.
Our next question is from Holly Jones. What was the behavioral health need increase for individuals under age 18? Where are they getting behavioral health care treatment? How much of the workforce is serving those under age 18? And are psychologists and psychiatrists in this study inclusive of child psych?
So Holly, we did not show any of the specific age bands. We do have the ability to do that. I think it's important to keep in mind that we didn't just run stagnant reports and put them out there, so we can go in there and look at that. Again, we'd like to get this turned more public and allow more broader access to it, so that people can go in there and query their own questions. When it comes to the psychologists, they are in there. I don't believe that the e-license data itself separates them out or identifies them as a child psychologist, so I don't think we have that in there, but if they put it in there, we certainly would be able to do that then at that point.
Our next question is from Kelly Nishad. Is the data just looking at the raw total number of licenses? For example, an RN as a license type isn't specifically tied to behavioral health. And similarly, social workers can be employed by managed care organizations, which wouldn't count toward impacting the behavioral health demand.
There is a, probably, I'm not the data scientist, I didn't write the stuff. So there is a bit of filtering looking at the total e-license data set like you're talking about, and then at the practitioners that are showing up as rendering to try and say, okay, out of that total workforce, this percent appears to be delivering direct services. I guess that's the best way to say it. But at that point, it's kind of agnostic of setting with the exception of where we can see it. And then it does extrapolate out over to the general population since we don't have an all claim payer database, if you will.
Our next question is from Penny Dainer. Hospitals and school systems have pulled many of the social workers and licensed counselors and are not available to mental health and substance use treatment agencies. Does the data take into account where the licensed individual is working?
The answer to that is a similar one as I just said. It looks at the entirety of the pool that's available and then looks at the entirety of those that we can that are practicing and then extrapolates that out over the general population. So it does accommodate that.
So Doug, does part of that extrapolation rely on the claims data that's available as well for both the board paid claims and the Medicaid paid claims? So that would help too. So if Medicaid or board is paying for services in a school, that would be inclusive of that. But if those are not coming through those claiming systems, it wouldn't be.
Correct.
Okay.
David Mattia asked, is it fair to state that the market increase in demand for services correlates to the expansion of Medicaid? And he also asked, what, if any, plans exist for loan forgiveness programs to attract workforce?
Can you repeat that second question? What, if any?
What, if any, plans exist for loan forgiveness programs to attract workforce?
No, I forgot the first question. Doug, do you remember it?
Is it fair to
No.
state is it fair to state that the market increase in demand for services correlates to the expansion of Medicaid?
Okay, on that one, please keep in mind, I said we did not drill down into exact causes of those correlations. We just looked at them and said, this is what the data shows as a correlation. Now, we might have ability to look at some of those later on, but we did not want to try and influence with things that we knew were going on, like Medicaid expansion, BH elevation, and the public health emergency.
With the loan repayment and tuition reimbursement, those are strategies that have been successful in Ohio in the past, that as we did our look at the landscape across the country, those are strategies that are used in other states as well. So we would want to work together with the workforce team that's being assembled at the state and all of our community partners to develop those strategies. If the funding source allows the use of dollars for that, and that will be a limiting factor on what we can and can't use these relief dollars for, but will help us shape what we might seek other funds for over time.
And our last question for today, folks are asking if they can get a copy of the slides or if this recording will be posted.
Yes, both the slides and the recording will be posted on our website.
Excellent, thank you so much.
Thank you, Nicole, and thank you, Doug. Thank all of you for attending today. We know this is the first of many conversations around this data set that we'll be having together. And so we'll be stay in touch, watch for future events related to workforce and how you can get involved. Thanks for your time.